Hello.
Good afternoon. We are live. My name is Simon Latimer, and welcome to this, the first in a series of Ask a Clinician webinars from Let's Do Digital. This one is titled Understanding Clinical Decision Making Insights from a Medic. Format today will be a half-hour presentation, half-hour Q&A. If you have any questions, then please in the comments by question, and we'll pick the best out as we go. I'm going to jump across to our presenter today, Mark Berry, Locum Respiratory Consultant and Clinician-who-codes. Have a
Thank you so much, Simon. So, yes, this is very exciting, everyone. Thank you for being here. First of many, I hope, of these Ask the Clinician series. And let's just jump straight in. So, well, let's start. Why did I start this series? So I was at Rewired this year, and I was speaking to a few colleagues, some in digital, some in clinical, and the digital folk were asking me, talking about how why haven't we got actual teaching for people in digital about clinical skills and clinical knowledge and so on? And I thought that's quite interesting. And I spoke to a few other colleagues that said, "Oh, it's just something we should do." And so here I am teaching about it. Now, I was originally going to talk about more clinical stuff, like how often does the lung divide, the airways of the lung divide, 24 if you wanted to know. But people started saying they really wanted to actually understand how medics think, work, do, what's their workload like, what's their workflows like, and how do they enter data into our electronic systems in healthcare, so EPRs and so on. And how do we clinicians manage to screw it up? These beautifully written user-centered design things that we're asked to put data into, and why do we put in to be confirmed TBC or anything like that in fields when the digital folk, the computer scientists and so on really want to know these bits of data, but us clinicians just go, no, haven't got time for that. So I thought I'll try and help people get into the mind of a medic, or at least my mind, a bit of inception, if you will. So let's jump straight in. So with this webinar series, I thought it'd be interesting to get different clinical specialties to talk as well. So I'm coming at this from a medic, but we've got nurses, dentists, pharmacists, paramedics as well, and a few other people lined up as well already. So I'm looking forward to those. But this is my version of the truth from being a clinician, interactive digital. So this is something I wanted to start with. Where are we the same? Where are we different? Us digital folk and us clinical folk. And I sort of lie in the middle as a clinician who codes. I sort of understand both worlds, a clinical informatician and different names like that. But I do think doctors and computer scientists, digital people, if I can, cluster you like that, we're all really the same. We're all trying to fix bugs. Doctors, it's viruses and stuff, and for in the digital world, it's fixing bugs in the code. But we're trying to fix something and get it back to normality, or as best as possible in terms of health, because you can't always with chronic diseases and so on. But this is where we differ. And a doctor's main concern is with the patient, naturally, of course, their safety and the control and the fixing of their health. And this is ingrained in us at med school. The GMC, the General Medical Council, ingrains this in us. The first thing we have to do is, as doctors, is think patient safety overall. Do best for the patient, don't do harm, autonomy, and all of that jazz. That all comes first, even before your own health, really, the way that it's written in the GMC guidelines, which, you could argue, make sure the doctor's healthy before they're looking after the patient, but that's another story in itself. But overall, the doctor is focused on what we can do to make sure the patient is well managed from a medical perspective and treated well, and don't make complaints, make sure you've got the patient on board, what you're trying to do, and actually working with you. And if I may be as bold to say this, on the other hand, people in the digital world, their main concerns is gathering the data that we create, whether it's good or bad. Most of the time we could argue it's not great, and then fixing bugs in code. of course, this is a gross oversimplification of things, but I thought it was just interesting to see where we're similar and where we're different, to see if that can sort of help people looking at their data in the digital world to try and understand better what it is us clinicians have done to make that data and maybe make it more understandable for yourselves. So why aren't we understanding each other? We're all really working on the same big issue, patient care. You know, but the exchange of information, data is just not happening that well. So the question is why? So most doctors, apart from those in sort of have understanding of both worlds of digital and clinical, most doctors don't understand what digital really is and what digital people want from them. And there's a rare breed, if I may say, of clinician that understands both clinical and digital aspects. They are clinical informaticians. Myself, I call myself Clinician-who-codes because I can write code. I actually enjoy doing that to try and solve the digital problems that we have. Of course, there's no certification or registration of this specialist role yet. Hopefully one day there is, but you know, there's going to be different caliber of clinical informatician. Not to say there's bad ones, but you know, they vary in their knowledge and sort of sometimes breadth of knowledge if they haven't had you know, exposure to certain areas of clinical informatics, so the digital healthcare sort of Venn side diagram. And then the other side of the coin, most digital folk do not understand what doctors do or really think, and why doctors do not fill in the digital forms that, you know, they've perfected the layout and the data that they want to get. And this brings us to the crunch point. And this is probably a bold statement, but I thought I'll put it out there. Doctors find data entry distracts them from the important task of fixing the patient. This is sort of a quote unquote, if I may. But basically, you put an EPR in the way of a doctor, and they're going to just fill it out quickly just to get back to the patient and doing what they need around the patient, which I'll go into in a sec. And quite a few might have seen this already. I put this on different social medias, bit of a poking at the issue, but I thought I'll show it up here again for those that haven't seen it. So the digital divide, on one side of the canyon, doctors asking for a single button. This is me, by the way. You know, I as a chest physician, I want to organize chest x-rays all the time, but why do I have to, you know, log into a different system, put in the patient's credentials, say what it is, say it's the right patient, click it, wait for it to come back to say it worked or not? Why can't it just be like, this is my patient, click on the button, x-ray done? And I feel that what I'm asking for is not heard on the other side of the canyon in the digital arena. And we don't get what we need to actually do what we need to do to look after the patients. Anyway, this is poking fun at the problem. So let's be a fly on the wall and see what it's like to be a clinician. So what's the day like being a doctor? Hopefully this will help you understand a bit about our difficulty with giving you correct information in the systems that we use. So let's start with junior doctors. Now, technically, junior doctors are anyone that is not a consultant, but I'm going to use this as doctors that are not middle grade, so registrars or staff grades, and not consultants. So the junior doctors do a lot of the legwork, especially around digital. So let's start there with them. Now, let's start with inpatients. So this is emergency admission. Patients that come in, you know, bad cough, chest pain, whatever it is. Now, we will get taught A, B, C, D, E, so airway, breathing, cardiac disability, and extra. So basically looking at the patient, make sure they're in a fit state, actually sort out any problems with their airway, breathing, and so on. If a really unwell patient comes in, that's what you hit hard first, you know, and you kind of subconsciously assess this with every patient. But of course, you know, there's the end of the bedogram where you look at the patient going, well, they look fairly well. Let's just do what we need to do next. So what do you need to do when you see a patient? You know, patient has a symptom, they come to hospital. The emergency department, they get seen by, well, they get admitted. There's whole processes with that as well, through whatever route it is, and then a doctor sees them. And in the they take a history. So you ask, what's the presenting complaint? Bad cough, doctor. I'm bringing up sputum, shortness of breath, stuff like that. And then you take lots of history around that, background history, smoking history, family history, social history. There's quite a lot to ask. Then you do an examination. Now, 80% of your diagnosis is made on the actual history alone. The examination just confirms what you've been thinking. And then you formulate a treatment plan. So let's say with the symptoms I gave you, it's a chest infection, someone that's got, already known lung disease of some type. So you're like, they need some antibiotics, they might need a bit of oxygen, they might need some fluids because they're a bit dehydrated from being on well, not eating and drinking very well. You prescribe some antibiotics and fluids and so on. You need to go and write those down either on a piece of paper or a digital system. You write down everything that you've heard, you've seen, that you want to do and you think, wherever it goes. Now, there's some hospitals that still are not electronic, so these are electronic clerking forms. And the word clerking just basically means doing all those things that you do when a patient comes in history and so on. And then in some places, depends if you're lucky or not, you might have to actually do the blood yourself, consent for procedures. Let's say a patient has fluid around the lung, they need a chest drain, you need to consent them. That's a piece of paper. There's digital consent forms as well in some lucky places. But there's a lot going on already for that one patient that's coming in. This can take you for a, averagely unwell, shall we say, if there's such a marker, averagely unwell patient an hour. And when they're really unwell, this could be 2 or 3 hours of your time dedicated to that one patient. And if anything gets in the way of doing all that work around that, and this is literally all the medical side of that, all the sort of the admin and the digital side of things, that can really slow you down. So you can see there's a lot going on already. And then bring on an extra bit of work. It's like, this is why we don't interact so well with digital. Be it good or bad, probably bad. So there's procedures to do. Let's say chest X-ray, chest drain, lumbar puncture if someone's got maybe meningitis or something like that. You need to do referrals, how it's call someone, write someone, email someone. There's different ways to do it, and different specialties have different ways they want to be contacted. Sometimes a bleep, so you wait around waiting for a bleep to be answered and so on. Chase, after a few hours, you need to chase the results and the referrals and so on. Answer patient questions, answer relative questions. That can take a long time, especially when the relative's very unwell, understandably. But you get one relative for one patient and another one asking the same questions. Like, then you have to sort of say, can we just have one patient representative, of the family to talk to? You might have to reassess the patient. You should be reassessing the patient, especially if they're unwell. When the patient is well, write a discharge letter. Discuss the patient with your seniors for what your plan is. So this could be with ward rounds. And hand over the care to the next team. So if the patient's going from the acute medical unit, which there's the sort of linear progression of most patients, they have symptoms, they come to emergency department, they go into the acute medical unit, and then they go into the wards when they're more stable. And so you need to hand over that patient between each care unit, shall we say. And so you have to make sure you've got the history right and all the investigations right. But also during the night, the evening to the night, you have to hand over to the evening team if there's a very unwell patient that you want them to review. So, lots going on. And there's still more. You, as a junior doctor, you have to go to teaching sessions. This can be once a week, sometimes more. You need to get involved with quality improvement projects at least once a year to pass the year. It can be something as simple as venous thrombus risk, so deep vein thrombosis risk assessment audit. Rather dull, but I've been there, I've done that. You need to do it. But it's still there. It's stuff you need to do around all your other work. You need to attend clinics for your own learning. So this is sort of when you progress a little bit further, maybe than the first or second year foundation doctors. You need to keep a portfolio of everything you're doing. So, the first 2 years of being a junior doctor, you need to show you can do a cannula, you can do blood pressure, all the simple stuff and build that up. But you need to show that you're competent in that, someone to sign you off. So you need to find time for you and that person to do it. And you've got yearly appraisal. It's a lot going on. So middle grade doctors and consultants, what do? That's different. So technically, it's a lot of the same work. All the things I describe in different ratios. So, seeing the patient and taking the history again, examining the patient again, formulating your own plan, especially if you don't agree with the junior ones, and it happens, everyone's learning. You might, ask for another referral. You might need to have a certain procedure. So let's say registrar sees the patient, they think, oh, this patient needs a lumbar puncture. None of the juniors can do the lumbar puncture, so you'll do the lumbar puncture. You need to do quite a lot of the same work, but you're sort of giving more senior advice, more experienced advice to the juniors, and then you're leading ward rounds or board round. So if you've ever heard these terms before, a ward round is basically where a group of clinicians, and it's not just doctors, it can be nurses, physiotherapists, and so on. Normally it's a small group of doctors that goes around, sees each patient that they're looking after, talks to the patient, does the examination, checks everything hasn't changed, and then formulate a new plan or continue the same plan and so on. And a board round is where you basically sit in front of a board or a computer monitor on the wall or whatnot, where you actually talk through the patients and make a plan. And it's normally all the different specialties are there. So if it's on the ward, for example, you have the physiotherapist, discharge planning team, nurses, doctors, and so on. And then on top of that, you need to do not just the inpatient work, the outpatient work. So outpatient work includes clinics, basically. But for respiratory, it also includes bronchoscopy lists, so actually doing camera tests down the lungs for patients. So you have like a morning or an afternoon list. And, different specialties have different outpatient things that they do. So these are well patients that come in just for the procedure, have the procedure, get over the sedation that you give them for a few hours and go home. Of course, sometimes they have complications. And so actually you have to review the patient as well. Supervision, as I said before, and they lead multidisciplinary team meetings. So, for example, I help with the sleep. I subspecialize in sleep, so I do the sleep MDTs. It can be lung cancer MDTs, bronchiectasis MDTs, all the MDTs, to actually, manage patients with a certain speciality, subspeciality of disease. And admin. So much admin. It just piles up, and it's amazing. I used to say this as a junior doctor to my peers, that actually I feel like 10% of my workload is actually doing medical things. The rest is admin. It's crazy how much admin there is. Just all the different bits of paper, all the different calculations and medical risk scores you need to do, and all the calling up people and document that you've done this and that. It's crazy. It really is. But that's the nature of the beast, even before digital was here. So in outpatients, very much the same type of work, but different time scale. So, in the emergency department, a few hours to treat them, the 4-hour window. In the acute medicine wards, you keep them for a day or two. On the wards, you keep them for a few days, weeks. In some cases, like, for example, the stroke wards, it can be, months. We had a patient that was there for a year. But normally much shorter time scale, a few days to maybe a week or two. More than that, something's very wrong with the patient. But in outpatients, you're looking after chronic disease normally. So you are basically, you see a patient, you say, let's do some investigations. They go off, and a few days later, a few weeks later, have those investigations. The doctor would see those a few weeks later. This is a very different time scale. And then act upon them, see the patient in the clinic again 3 or 4 months later. Very different time scale. Same sort of things. You're still doing history, examination, investigations, and so on, but very different type of time scale. So I hope you can appreciate that there's a lot to juggle. And interestingly enough, if you're looking at who's actually entering your data into your digital systems, it's mainly the junior doctors, and quite a high proportion of the middle grade doctors that input the data into EPRs in the inpatient area. Because the consultant sort of leads the ward round, works out a plan, communicates the plan to the team, but then it's the junior sort of lagging behind, writing or scribbling what the plan is. In outpatients, of course, it's the doctor seeing, it's one doctor, one patient sort of scenario. So it's the doctor seeing the patient that actually writes up what they've seen, what they've heard, what they want to do, and so on into the EPR on paper. So that's normally the middle grade or the consultant. But remember, we treat patients, not EPRs. But the EPR is a huge part of what we do nowadays. So there was a study in the States, I have to look up the name if anyone's interested. I think it was about 3,000 EPR, 3,000 clinicians interacting with EPRs. So someone looked at prospective data from that to see how much time a clinician spends with the patient versus how much time the clinician spends with the EPR. 15 minutes with the patient, 16 minutes with the EPR. Now, I haven't got the amount of time it takes to do the same work on paper to compare to, because that'd be quite interesting, what the proportion increase is with paper compared to digital. But from experience, it's much longer. It is. Navigating digital systems to find the thing you need to input or read from, it just takes so long. Scribbling very quickly on a piece of paper in whatever form is very quick for the clinician. Of course, when someone needs to read it back later, the clarity of a doctor's handwriting is terrible. So, there's pros and cons, but anyway. So it's a question of data entry. It's a question of end user centered design. Now, COWS, computers on wheels. I love abbreviations. Doctors love abbreviations. My favorite one was GOD, G-O-D. Different types of clinicians on call. One of them was a geriatrician of the day, the God of the day. Anyway, COWS. So these are basically laptops on a stand, on a pole, on some wheels that you wheel around. And most places I've been, there's some that work, and then there's this little pile in the corner that don't work. We've got so much outdated systems in the NHS. Or someone who's lucky has a tablet or maybe a static desktop. If you're really old school, you have to go back to the computer at the desk each time you've seen a patient. The problem with that is that what I would tend to do, and this is bad practice, but go and see a few patients and then come back and write down what you saw for each patient. But of course, there's the risk of muddling up patients. There's a risk you forget what one of them said. There's so much you can only retain between patients. And then going on into more detail with the digital systems, there's hundreds of different digital systems in a trust, in a hospital. For me, on average, and for most medics, there's around 10 different systems, but there can be many more that I have to interact with. So we have the EPR, which is really, the monolithic thing that encompasses everything. But actually, I need to go and look at X-rays over there. I need to order a blood test over there. I need to make a referral by email, or I need to phone someone, or there's a special referral online form, and so on and so on. And you have to log into each of them. You have to find the patient in each of them, copy and paste the hospital number in each of them. And each of these tend to crash at least once or twice a day as well. And so we have poor quality hardware, and it's very slow and it doesn't work most of the time. We have poor quality software, which crashes. I'm in Bristol at the moment, and they actually have fairly good digital systems. They only seem to crash once a week at the moment, he says, but there are some weeks it's a bit more. When I was in another hospital, which I won't mention, it was at least once or twice a day, one of the digital systems I was using was crashing. Sometimes you have to restart the computer because of it. And so, this is just slowing down what we're trying to do, looking after the patient. These other things are getting in the way. The digital is getting in the way. Now, I'm a Clinician-who-codes. I'm a clinical informatician. I can see the benefit in digital. I really want digital to do what it can do best to help us do what we're doing with patients, but it's just not currently doing that. Now, you can't tell this on YouTube streaming, but I'm 6'6", and most digital hardware is not built for, well, most people, but for me especially, I have to sort of crouch to actually work at a computer. And the ergonomics around the computer, the cows, the desktops, and so on, the tablet that's really small with my big chunky fingers, you know, a lot of people struggle with these things. And, you know, considering we're a healthcare organization, the NHS, we're not looking after people very well. You know, the amount of people that go off with backache and so on is really, really high. But that's just a bit of a side point. But anyway. And so all those things, us doctors and other clinicians, of course, but I'm talking from a medic's point of view, us doctors have to look after the patient, have to do everything around the patient. There's so much to do around the patient. And then these slow, cumbersome digital systems get in the way. Doctors find shortcuts to get through those things as quickly as possible, around all the other tasks that they need to do for the patient and the other priorities they had, for example, QI projects and learning and teaching and supervising and MDTs and all those things. And this was a very interesting thing I learned from Harold Timbleby, who wrote Fix IT, very good book, by the way. Chunky thing, but a lot to learn. The idea of work as imagined versus work as done, aka shortcuts. And when digital systems are built, there's this idea of this is how it's imagined, this is how we think it should be used, and then actually us on the front line actually go, no, that's in the way, this is annoying, I'm going to go this other route, or I found this shortcut to actually do the thing I need it to do quicker to get to the, you know, back to the patient. Unfortunately, some of these shortcuts can be unsafe. So, you know, digital folk really hate it when we do shortcuts because it can be quite unsafe. So there's this idea of tactical laziness. You can read about it quite a lot online, where I think in some ways that's a very good way to describe this, that doctors are tactically lazy. We find the easiest way to do something because we have so much to do. So not overall lazy, but for each task, we try and find the easiest way to do things. And if that means in one of those pop-up fields that comes along when you're trying to, you know, order a chest x-ray, you just put TBC, to be confirmed. That's what we'll do if we can get through to that button that says X-ray, please. And so what can we do to help us poor little doctors actually help you guys get the data and the results that you need? So this is really all about end user centered design. It really is. Don't build what do you think the clinicians need as imagined. Do it as done. So if I want to get an X-ray within one system, get all the data that you need from wherever it is and use that instead of asking me to input the same data and over. And design the systems around how clinicians think and how they work, so their workflows. Now, of course, different people, clinicians are people, so we all think differently, really. But there are a lot of things that we do similarly. You know, we need to enter some data about something. We need to retrieve some data about something. We want to press a button to do something. And, you know, you could, but then doctors and nurses and pharmacists all work slightly differently. So, you know, you might have to slightly different system layouts. So there's an issue. It's not something easy. It's not something going to fix overnight. But trying to make systems work better for the person using it, and maybe you can have it modular. So, you know, I can move the button over there if I need to use it all the time. It's ideas I've had. Worked with some computer science students on building those ideas. But make it as easy as possible to do the right thing. Then people won't find shortcuts. You know, don't have to. So when I used to look up blood tests, I looked into the steps to look up a blood test for a patient. It took me 37 clicks on one of the old systems to get that blood test. It was crazy, you know. Yeah, and center the digital systems around, well, the digital systems and the data acquisition around the patient and the clinician, not the other way around. Right. Over to you, Simon.
Hello. Okay, we're back again then. Okay, so thank you for that. That was a wonderful presentation. Very informative. And there is, I am from the opposite side of the divide. I am one of those IT providers that 17 years ago was very much the kind of, why are you putting TBC here? That's not how it should be done. And Yeah, although I pray indeed that in the last 17 years I have improved, and I have taken some time to learn how the clinicians around me actually work. So we've got just the one question from them so far. Jeff Revel says, given the history is taken in every engagement with a clinician, why does every consultant/doc start every meet with asking the patient to take them through their symptomatic history? So why is it kind of rolling through?
Why does every doctor ask the same question and repeat?
Yeah.
That's a great question. God, why has no one ever asked me that?
Go, Jeff.
Patients, I know, no, that's not true. Patients ask me that.
Mm.
Doc, I literally just told your junior the same thing,
Mm.
an hour ago. Why am I repeating it? Well,
Yep.
the short answer is that's the way we're taught to do it. Now, the longer answer is, should we really be doing it that way? Well, there's some benefits to doing that, and then there's some risks of doing that. So the benefits are that patients recollect a bit better each time you ask them. Because the first person that asked them, they sort of said, I don't know, this thing happened. It's like, what thing? Well, I coughed a bit. And then you go away and come back. And then the patient starts thinking about the cough. Oh, actually, I was bringing up some blood in that cough. Or I had some chest pain over here. And it builds up the story. But there comes a point, there's a saturation point, isn't there, where like nothing new is being added by the memory of the patient or they're thinking about the problem. And then it just gets annoying for the patient when they've had to answer the same questions. And let's say someone comes in a chest infection. Let's say they start with a GP. They go and see their GP. They tell the GP their symptoms. The GP says, you need to go to ED, emergency department. You go to ED. Oh, you talk to a doctor there, and they get referred to the medics. A junior doctor sees them, and then a middle grade doctor sees them, and they say they need to go to ward. And then they go to the ward, and then a consultant on the ward sees them. Oh, there's triage as well in there, another thing. So, there's 5-6 times in that 24-hour period that a patient has to say the same thing. Now, it's written on digital systems, but I think there's ingrained into us that actually we should be asking the same questions over and over. But also, how much do we trust what we see written down and asked by someone else as well, or written down on paper or on an EPR? How accurate that is. And I do see it that when someone asks the same question again or start thinking differently, depending what the answers are on the repeat, you can change the diagnosis. So it's a risk benefit thing, and I don't think anyone's perfected it.
To me, it sounds like there's a combination of trust in the systems itself, and there is obviously medics, you're all guys risk averse folk anyway, naturally. So this is a risk averse way of looking at it. Let's belt and braces this whole process all the way through. And despite the fact that you have a clear clinical record alongside it, there is a question mark. And actually your whole presentation kind of leans towards this. It says, well, actually, I'm not too sure about the way these work. I'm going to do this extra thing as well, just in case, and that makes perfect sense to me. Next question from Jill Winters asks, how do we design a clerking program language that addresses accuracy as well as efficiency? There was a couple of comments in there that actually, that's a very good point. Certainly from the times that I've actually gone through with some of my clinical colleagues about agonizing over the fact that something was put in incorrectly or late or something similar. How do we make that better? What does that look like? How does that work?
The language as in human language or the language of the computer?
That's an interesting one. That's effectively a bit of both. I would imagine a human language basically, but it includes, I would imagine, building a system that actually works in the first place to capture that properly and efficiency. What does good look like?
So, I like to think about these things as transformation with or without the aid of digital. So it might not always be digital that's actually going to give you the answer that you need. Now, you might argue, oh, doctors have perfected the way they do clerking, over the millennia since, the Hippocratic Oath started and so on. But, I think there's areas that it can be improved upon. Now, how to get the digital systems to help us do the clinical clerking for inpatients. So we can talk about the outpatient world as well for inpatients. Well, you could actually ask all those patients that are sitting on chairs in the emergency department to fill in forms with all the questions you're going to ask them anyway. I mean, for example, for my sleep service stuff, so let's go to outpatients work, I asked the same questions for all the patients. Quite repetitive work. Now, one of the reasons I'm staying in it is because I can see that digital could fix it quite easily because it's so protocol driven, so repetitive. But why? And we do ask patients to fill out patient performers, but why not digitize it and actually, you can start using AI and stuff like that. But let's not go there. I'm all about getting the basics right first.
It's a little bit far for this conversation.
Yeah. So why not digitize it and then actually present to the doctor? And the doctor said, "Oh yeah, you said you're sleepy. You said you're overweight. You're a smoker. Well, let's talk about those things rather than me having to take a long time to ask these things." And it was just streamline how I work with the patient. Now, some people might not trust what the patient's put down because you need to think, is the patient telling the truth on that or not on there? Because when a human asks, you think, oh, they're going to give you more truthful answers. But it's interesting. There's been some studies looking at how patients interact with digital, like AI chatbots, especially around sleep or mental health. And apparently they're more truthful to the digital system because they don't feel like they're going to be, judged for what they're saying. So it's interesting. But would you feel more judged when a human's going to be looking at that information later? I don't know. But when this computer program says, how are you feeling today? And, it's not really going to be used tremendously by a clinician as such, but it's just really trying to help the patient verbalize how they're feeling and walk through their problems. They can actually interact better with digital systems.
Is there an element of white coat syndrome in that, do you think? Just being kind of slightly nervous of the whole kind of patient-doctor scenario? I mean,
it's interesting. Before, when I was a child, before I knew that you actually go to med school, I thought you were born a doctor. It's this hatch from an egg, the doctor egg, and there you are with all the doctor knowledge. And I thought it was a special breed of people. Well, they let me in med school, so it's not that special, But is it white lab coat syndrome? Well, we don't wear white lab coats anymore, but the saying's still there, at least in the UK. Yeah. It's real. Blood pressure is so much higher when you go and see your doctor. When you're going to go and do something that might be life altering, about your health, it's scary stuff. So why not ask maybe robots without a white lab coat on to ask questions? I don't know. I would really love some big number studies to look at these sort of things.
That'd be interesting to see. Okay, so next question is from, get the actual name right, Amadeus X, I think. PSX, have you encountered any good examples of UX outside of your day job, which you would like to see elements copied or replicated in the day job? So let's paint from other parts of the IT sphere or other systems and solutions out there. Is there anything you want to pinch?
So many. I think my favorite idea is, sorry to put a brand out there, the App Store from Apple. Now, an idea I have, a lot of people have this idea, it's all about the interoperability, really, is actually you have all the data with the same data structure across all systems. Wouldn't that be nice? But anyway, we haven't got that yet. But the same data structure across all systems with the same interoperability, FHIR, HL7, whatever it is. And then on top of that, you drop an app that interacts with that data. A patient's blood pressure is a blood pressure. Now, I've had people argue, no, it's not. Depends how you do it, what machine you use it. It's like,
yeah.
I mean, at its core, there's a systolic and a diastolic blood pressure. Yes, they're lying, they're standing. There's all sorts of variables around that. But, those variables are all the same, really, almost binary in a sense. And so the data really should be the same for each patient, blood pressure is blood pressure, heart rate is heart rate, heart rhythm is heart rhythm, and so on. And then you drop in an app, let's say the sleep consultant app for Sleep Clinic app, that will show me all the data that I need. The weight, smoking status, sex, background history, and everything I need. And I'll look at that, I'll triage it, and triage is just a French word for actually looking for truffles, but it means I'm pulling through the truffles, the people coming through and saying what they need to be treated for. So triage them to say, oh, that patient actually, it's unlikely for them to sleep apnea syndrome, the condition I look at, breathing problem at night. So I'll discharge them. Or no, that one might have it, so I'll organize a sleep study. Or that one has something else, I'll organize a different type of sleep study. And why not have like the summary page with all the functionality in one place? And I've tried to build that with some of my work with Spirit and Duo, which we're trying to implement in Oxford University Hospital for hematology cancer treatment. Trying to get that sort of idea of building the system to work with me, giving the things that I need routinely. Of course, you have edge cases like, oh, this patient has this other disease, I need to organize some other test. But all the things that I do over and over again, why not have them available at my fingertips? Because that would just streamline it and make me happier working with a system. I mean, the burnout rate of clinicians is really high. And one of the factors behind that, it's well documented, is EPRs and the frustrations that we have working with them.
That's really sad. That's really sad. I mean, do you have any sense on how many we lose in the process of doing that? It's obviously a promising young med student comes in and goes, oh my God, it's awful. I'm not doing that. Is that a common thing?
It's fairly common. Now, I can't remember the numbers, but it's like 20 or 30%. I do have the reference I can bring up another day. It's high. It really is.
That's quite scary. That's quite scary. Next question, unless we fish that. From Nadia basically says, what do you think needs to happen to enable grassroots digital development in the NHS? What are the sticking points you encountered? Funding, skill sets, mindset?
Okay. Well, this is a good plug to something my friends and colleagues are doing with the Clinical Digital Manifesto. Go to the website, have a look after this talk. Dr. Marcus Bohr and Tom Stocker, who started this at Rewired, and another plug, I'm going to talk about it at the Let's Talk Digital Conference in October. They have outlined 5 steps or 5 big topics that they want to cover. And yes, one of them is grassroots in there. Actually, let the clinicians help lead the change that they need. Now, a lot of people who are trying to implement these digital things think they are getting the clinicians involved. They ask them to come to the meetings. You know, let's have a stakeholders meeting. Let's talk about how you want your cardiology service to run, or gastroenterology or whatever. But the problems with clinicians is they're very, very busy and they can't come to meetings. And it still happens where they get asked to go to a meeting which they can't go to because they need to give 6 weeks notice to cancel clinics. So, you know, it's this real big lag time. So actually getting clinicians who haven't had devoted time for digital engagement or any project that involves quality improvements, for that matter, it's not just digital, it can be really difficult to get the clinicians to actually help build those things unless you give clinicians time towards it. So I guess one of the first things I would say is have dedicated clinicians, doctors, nurses, pharmacists, and so on, to actually help with the grassroots stuff. Now, there are clinicians who do this. So, you know, there's the CCIO, so the Chief Clinical Informatics Officer, the Chief Medical Informatics Officer, the Chief Pharmacist, and so on. But they're very much about just trying to implement the system, a bit of stakeholders engagement. But I think you need more people, and everything's going to be digitized. Everything is digitized outside of the NHS, but everything's going to be digitized in the NHS. So why not actually get people more involved with building the digital stuff that works for them? Now, there's also the argument some people just don't want to work with digital. They just, you know, they've had so many times burnt by that system, or it doesn't work for them. Yeah. So there's so many things we can do. I think giving clinicians time to actually help build the systems that will help them and colleagues is a great first step.
Gotcha. I've got some of my own questions here now. So you mentioned, obviously, talking about cows, talking about the existing infrastructure. Clearly, that's a lot of money to be spent on hardware alone. I'm curious to think, are there any quick fixes that we could do around kit alone? If we look to the infrastructure alone, or is there any kind of that, or is it really just a simple matter of stumping up and paying the cash for some better equipment, or is there another place it can happen?
So, I mean, there's hardware and software. The software is probably a bit harder to do right. That needs a lot of engagement. But the hardware really is just hardware. I'm not sure we need anything special in the NHS, just something that we can, you know, interact with as humans. And there's a lot of it, like we're both saying, that doesn't work. Now, just throw money at the problem. I don't think that will work. I think you need a proper service for monitoring computers and other hardware, actually, obs machines and so on, but a proper system. And I haven't really gone into this in detail in terms of thought, but a proper national system that actually monitors the functionality of computers, probably feeds back to a central, trust-wide place that says, oh, computer 2167 is actually, running at 40% capacity because of the fans overheating or something, and get someone on that. But most of the time, it's us people on the shop floor that have to, log this problem, and it takes forever to fix it. It is money. You are going to have to make sure you fix broken hardware, but then you should argue getting good quality hardware, but also systems to actually make sure that hardware is running at, optimum, whatever that is, capacity to actually help us do what we need to do on the shop floor.
Fabulous, fabulous. Quickie one. EPR design. Obviously, you did a pretty good job of not kind of slating it, because I completely agree. From those that I've worked with, there are very few good examples. But let's talk about those good examples. Are there any pockets of excellence, good systems that work, some exemplars that we could hold a light up to and say, well, this is what we want?
I'm not sure I want to shout names out of systems, because they've all got good and bad. Okay. But I have seen great functionality for certain things in one system and certain things in other systems. At the end of the day, I mean, you can make the screen look as pretty as possible. That's nice. But like I said, because us clinicians are time poor because of all the things we're doing, actually, if you can make something work just really quickly and it's intuitive, that'd be great. When I was in Gloucester, we used to have a DOS. So for those that don't even know what that means, disk operating system, operating system. This was it was in a virtual environment, software to interact with microbiology and bloods. It was the fastest system you had ever seen, because all you did was type in different combinations of keys to get what you wanted. And you would memorize them. You didn't even look at the screen. And even if there's a bit of a lag, like, if you type in this combination, enter, this combination, enter, this combination, enter, look array, have a sip of tea, come back. The results are there after a few more seconds. It's about getting what we need to be done or seen done as quickly as possible.
So it's actually the transaction itself then. So it's making that transaction
more important.
Really.
So actually, really, that DOS system was one of the best systems. Once you got used to the oddness of a DOS system in the year 2000, and what was it? It was just a few years ago we got rid of it. That just the functionality itself is the most important thing, I think. Now, I mean, going further than that, what have I seen in other systems? I don't think it matters, actually. It is really about getting me to do what I need to do as quickly as possible on your system. If you can fix that, it'll be great. It'll be amazing.
It would be cool. No, I mean, don't worry. I mean, I'm sure if we cast around, we'd still find more than a handful of DOS-based or very, very old-based existing systems that are still being carefully looked after by very old IT dudes. This is somewhat a cheeky question, but obviously we did cover bits in the what do we need. If we were invited up to the Department of Health after the next government's brought in place and asked to give 5 things that we could do quickly, what would they be?
Have a clinician who's still practicing clinician in charge of the NHS.
Yeah.
One that doesn't mind saying what they need to say, that this and that is what we need. So, have a national CCIO who has the balls to say what they need to say and do what they need to do. Because it's fairly ugly out there. It's fairly bloody out there, and so much needs to change. Now, I know there's not a lack of money, even though people might argue otherwise, because we are spending, extortionate amount of money on systems that we may or not need. Like, the federated data platform, 360 million on that. How much money would that be for staff that need that kind of money? Other things as well, the National Program for IT, 12 billion. How much do we get out of that? We got a few systems out of that, but really very little.
NHS mail, I think that was the real.
The spine, some radiology stuff, yeah. But the rest of it, no, because they wanted to build a national monolithic EPR. Didn't see that. So someone to lead it, and then someone that can actually say, this is what we need to change, actually fund it, because actually a lot of people on the stream now will probably understand this, that actually money's being pulled back from digital, even though governments are saying we need to digitize everything. Actually, the money's going away. We're downscaling staff, we're downscaling systems.
Yeah.
So we need money. But put your money where your mouth is, basically. We need money to actually make these things happen. So we got there. 3, 4, get clinicians on the front line actually engaging, giving them time, paying for their time, not just saying, oh, come and see us in your 20-minute lunch break and say what you think about this system, which you can't even interact with. We're just giving you a nice slideshow. So actually pay for people to do these things and help interact with these things and get other clinicians involved. And then 5, actually build, I don't know what you would call them, but entities that help people at the front lines, the bottom-down pull rather than the top-down push. There's so much evidence out there that the top-down push rarely works. It's the bottom-down pull you need, because we know what we need. To enable people that know what they need to actually build the things with someone else's help, or build them themselves if they're Clinician-who-codes or something like that, to actually build better systems. That would be my 5, just thinking on the fly.
Okay, that's a good one. So wrapping up, Nikki has a kind of question, says basically sounds like secondary care needs something like the systems primary care have, which is a very good point, because they do have many of the functions you've already mentioned. I dip into both worlds in my day job, and I do use a system that is designed for primary care, and it's a very different beast from those that we deal with, certainly in the acute sector. Your point earlier about having 10 or more systems, and that's on the light end. I think I know some clinicians who've used many more than that systems in a single clinic. The kind of monolithic systems that they do have for primary care, they do seem to have kind of squared the circle, where we do have 2 systems, EMIS and System 1, that are configurable and customizable at the primary care clinic level, to do exactly what that clinician requires. They're by no means perfect, but they are certainly a step ahead in terms of that integration level, because they're all in the same system. There's no kind of having to pull data or push data into them. So it is an interesting dichotomy between the 2. Have you had a chance to look at those?
Yeah, no, I've interacted with digital systems primary care mainly as a med student, but I hear about it quite a lot from my GP colleagues. And yes, they have. I mean, the GPs digitized most of their workloads back in the 1980s, 1990s. I mean, they have digital prescriptions for outpatients. Why can't we in secondary care, tertiary care, actually do a digital prescription and send it to the local pharmacist? We don't have that.
I know. I've run into exactly the same problem. I don't know. I don't want to talk out of school, but I think the last answer I got, and obviously quote me on this not, is that there was a CCG, or it was an issue around governance and exactly where that lived. But we have
but it's interesting. I find that anything's possible if you put your mind to it. Like, come COVID, February 2020, we suddenly can do lots of meetings online.
Oh, no, don't get me wrong. It was the gloves were off in that respect, and I was given the one and only time a little bit more free rein to just make it happen. And things can happen in those kind of time frames. Absolutely.
So for anything frontline to happen, you need to have top peers actually allowing it as well. You can say, oh, governance is not allowing it. It's like, no, COVID came along, governance suddenly disappeared. Not to say governance should disappear, but we shouldn't have so many blockers.
True enough. True enough. Okay, so that brings me to the end of all of the questions. Have you got any comments or anything else you want before we wrap up?
No, but I would love to hear from people in the chat or email me, mark@letsdodigital.org. If you've, what topics would you like to hear about next? Honestly, because these sessions, there's quite a few lined up. They're fun to set up and I think run, but you know, it needs to be something that people want to listen to and watch as well. So yeah, you know, just in the chat and so on, just say, oh, let us know what you want to hear more about, because I'm happy to deliver it.
Fabulous. I'm going to wrap us up with a shameless plug for Let's Do Digital, although I'm not actually well, I'm kind of a member of the team now, but it's mostly
Yeah.
Mark.
Yeah.
He is Let's Do Digital, let's be quite clear. Buy him a coffee, please.
Please do.
So I believe that's us for today. So thanks everybody for joining us. Next time, I'm not sure when is the next one. You get lined up?
Let's see. There we go.
There we go.
So the next Ask a Clinician webinar is on the 1st of August, but there's a few other things going on. The thing that I really ask people to look forward to is the conference. That's the thing I'm looking forward to. The program is now full, and we just need people to sign up and come and have a listen. It's hybrid and also in person in Cheltenham on the 24th of October.
Excellent stuff. Fabulous. It's been lovely to have everyone here today. Thank you again, Mark, and I hope everyone has a lovely rest of Thursday. And catch you next time.
Thank you so much.